The BeeleyTrocar is a specially designed trocar, which allows for extremely accurate placement of sutures in the abdominal wall at the port site in laparoscopic surgery. It can therefore be used to insert a single suture, several single sutures, or a continuous suture to close a larger port site. It can also be used to repair an established port site hernia laparoscopically, with speed and safety. A second adaptation of the trocar is designed for ligation of bleeding superior or inferior epigastric vessels, which may be damaged by the insertion of a port. This is usually a 5 mm port. All suturing is achieved through the original small port site incision. The trocar is manufactured as a re-sterilizable unit in aluminium, or as a single-use sterile polycarbonate unit. The essence of the invention is to have an angled conduit traversing the solid 12 mm diameter trocar, down which a suture can be introduced through the muscle layers of the abdominal wall by a suture-carrying needle. Such a needle is supplied in the re-sterilizable pack with the aluminium trocar and can be dismantled and re-sterilized with the trocar. The lower end of the conduit does not enter the abdominal cavity so that no CO2 is lost, and the pneumoperitoneum is maintained so that the suturing process is viewed through the intra-abdominal telescope. At the distal end of the trocar are 3 circular markings. In the average-sized patient, the upper circular marking is lined up with the peritoneum at the port site. The needle will then enter the peritoneal cavity 1.5 cm away from the circular marking. The trocar must be held vertically, i.e. at right angles relative to the peritoneum. If the patient is considered to be more muscular than average, the second circular marking is lined up with the peritoneum, or even the third circular marking, and the needle will then take a bigger bite of the thicker muscle tissue. There are 3 conduits drilled through the trocar at different angles. This is to allow for varying degrees of obesity of the patient. On insertion of the trocar and lining up of the appropriate circular marks, the needle is inserted through the lowest conduit still visible above the skin. In an obese patient, this will be the top conduit. However, the needle will enter the peritoneum at the same point, 1.5 cm lateral to the upper circular marking, because of the differing angles of the conduit. In line with the exit points of the 3 angled conduits is a dotted line, marked on the distal end of the trocar. In line with the entry points of the 3 angled conduits is a continuous line on the distal end of the trocar. These lines can be seen easily within the abdomen with the telescope and allow for accurate orientation of the suture process. When the top circular marking is lined up with the peritoneum, the needle will enter the abdominal cavity 1.5 cm radially away from the dotted line to introduce the suture. When the trocar is rotated through 180 degrees, the dotted line is no longer visible. But if the now visible continuous line is aligned radially with the entering suture, the needle will enter 1.5 cm radially away from the now invisible dotted line to retrieve the suture. On removal of the trocar, the suture will have been placed accurately across the port site. The second adaptation of the trocar is designed for ligation of bleeding epigastric vessels damaged by the introduction of a 5 mm port. The distal end of the trocar beyond the exit points of the angled conduits narrows down to 6 mm, so as not to further dilate the tract through the rectus muscle, which may possibly occlude the bleeding points. The suture-carrying needle can be dismantled for re-sterilization. On depressing the proximal plunger, the sprung distal blades open to grasp the suture, which is then carried back into the needle on release of the proximal plunger. Having passed the needle through the trocar into the abdominal cavity, the suture is released by again depressing the plunger. The needle has 3 circular markings towards the distal end, labelled low, mid, and top in situ retracted position. These refer to the low, middle and top angled conduits. When the appropriate circular marking on the needle is visible just above the entry point of the appropriate conduit, the needle point has been retracted back into the trocar, which can now be rotated without damaging the tissues. See continuous suture section. A knot pusher is also supplied to enable ligation at the level of the muscular abdominal wall without having to enlarge the port site incision in an obese patient. The port is removed from the port site to be sutured and the BeeleyTrocar inserted. Any leakage of CO2 which may occur if the port track and skin incision needed to be enlarged can be controlled by stapling of the skin incision snugly round the trocar. The trocar is adjusted until the upper circular mark is level with the peritoneum. The dotted vertical line is aligned appropriately, and the suture-carrying needle is inserted through the lower conduit and enters the peritoneal cavity 1.5 centimeters away from the trocar. The trocar is now tilted towards the intra-abdominal portion of the needle and the suture released directly below the entry point of the trocar. The needle is withdrawn and the trocar pulled outwards to reveal the lower end of the conduit so that the suture can be retrieved to lie at the side of the trocar instead of through the conduit. The trocar is rotated through 180 degrees and the top circular marking realigned with the peritoneum. The needle is reinserted and the trocar tilted to retrieve the suture from directly below the port site. The loop is pulled tight, observing that bowel is not caught up in it, and the trocar withdrawn. The knot is tied and the throws pushed down to the muscular abdominal wall with a knot pusher if necessary. The tilting of the trocar to lay the suture directly below the trocar enables the suture to be grasped again without the need to insert a separate pair of laparoscopic forceps through another port into the abdomen. If forceps are already in use in the abdomen, these can be used to manipulate the suture into the jaws of the suture-carrying needle. The procedure starts as for the single suture up to the stage of rotation of the trocar. The needle is then reinserted and the suture grasped by its jaws and retracted into the needle. The needle is then pulled back into the trocar, the successful completion of this manoeuvre being indicated by visibility of the appropriate line on the needle at the upper end of the angled conduit. The trocar is now rotated through 90 degrees and the needle reinserted and the suture released again into the abdominal cavity. The needle is retracted again into the trocar and the trocar rotated a further 90 degrees in the same direction as before. The needle is reinserted to retrieve the suture. There is now a purse string around the port site. By adjusting the rotation of the trocar, the surgeon can apply the continuous suture across the port site. The orientation marks on the trocar allow the surgeon to place the sutures accurately to perform whatever closure he or she prefers in an individual case. Repair of an established port site hernia is performed laparoscopically with the BeeleyTrocar. A pneumoperitoneum is created and this redefines the hernia. The contents of the hernia are reduced back into the abdominal cavity. The end of a sucker is pushed up into the hernial sac from within the abdominal cavity via a 5mm port. The sucker is pushed onwards through the peritoneum at the apex of the hernia and on through the fat until the end is palpable under the skin. A small incision is made over the palpable end of the sucker and the tip of the BeeleyTrocar is engaged with the end of the sucker. The trocar is then railroaded into the abdominal cavity. The hernia can then be repaired as described before. This injury is usually caused by a 5mm port. If abdominal wall vessels are damaged by a 10mm port, then a wider BeeleyTrocar should be used for ligation. The second adaptation of the BeeleyTrocar has a narrow distal end, which on insertion lies in the rectus muscle layer, but the suture-carrying needle exits from the wider part of the trocar, superficial to the rectus muscle, thereby increasing the bite of rectus muscle to be sure of encompassing the bleeding artery. The suture-carrying needle is introduced with a dotted line at one side of the bleeding point, and the suture retrieved with a dotted line at the other side of the bleeding point. Tying of this suture will then occlude the vessel. The bleeding point at the opposite side of the port site defect will need to be ligated in the same way.